Hello, everyone. I'm Dr. Shri Banerjee, a chair for Claret, Dr. Onukogu. And here with us is Dr. Ray Panis, committee member, and then student Claret Onukogu. Currently, it is 1:06 p.m. Eastern Daylight Time, and the date today is May 24th, 2024. Let's go ahead and get started here.
All right, good afternoon. My name is Dr. Claret Onukogu, and this is in completion of my PhD in public health with a specialty in epidemiology degree. This is the final oral defense. The title of my study is The Association Between Psychological Distress and Diabetic Retinopathy Among U.S. Adults. All right, so a little introduction and a little background on diabetes. Diabetes is the inability of the body to respond to or produce a hormone called insulin. So depending on the type of diabetes, whether type 1 diabetes or type 2 or gestational, the body might not be able to produce or respond adequately to the hormone called insulin, which transports sugar in the body. According to the Centers for Disease Control and Prevention, out of the 30 million U.S. adults living with the disease, 1 in 5 of them are unaware that they have the condition. So we have people who have diabetes, but they're not, because they're not really showing much of any symptoms yet. They just don't know that they have it. So it's not been diagnosed per se. People who are pre-diabetic. Diabetes occur when the human body is unable to take glucose or sugar into cells and convert it to energy. So when, a human being, normal person, a normal functioning human being consumes food, it breaks down the food into glucose and then takes them to the cells in the body to use as energy. So, but in the body of someone with diabetes, the body is unable to do that. The body lacks the ability to adequately process and use sugar from food with diabetes, which causes damage and consequences to the tissues and organs in the nerves, eyes, kidney, and heart. So with that, inability of the body to properly process sugar, it starts to, over time, starts to affect, different parts of the body, the eyes, the kidney, the heart, and of course the nerves as well. Diabetes is the 7th leading cause of death and the number 1 cause of adult blindness, lower limb amputations, and kidney failure in the nation. So blindness is attributed mainly to diabetic retinopathy, which is what the study is about. The lower limb amputation, basically because of the lack of proper circulation of blood. When people have diabetes, that causes it could cause amputation of the legs, or any part of the extremities. And of course, kidney failure. Adults living with diabetes in the U.S. have more than doubled in the last 20 years, and it could be attributed to the diets as well and sedentary lifestyle. So diabetes just leads to excess sugar in the bloodstream, which causes damage to the body over a period of time. Diabetic retinopathy is common in people living with diabetes. So it's the damage of the nerves in the eye, specifically the back portion of the eye, the retina, that's responsible for vision, right? So diabetes tends to cause eye problems, with diabetic retinopathy being the most common. Eye problems resulting from diabetes can lead to blindness or vision loss. In working age adults living in the United States, retinopathy is the most common cause of blindness. So of course, when people were not diabetic retinopathy can't occur in younger people, but it tends to happen as people progress, live with diabetes for a while. So based on the findings from the eye doctor, so usually people who have diabetes, one thing they're supposed to do regularly is to go see an ophthalmologist or an optometrist to just get the regular eye exams conducted. So based on the findings, during the exam, the eye exam, the doctors can find out specifically what's going on in the eyes, if there are signs of diabetic retinopathy, if there's signs of nerve damage, and then of course suggest necessary actions that need to be taken. If patients prioritize eye care, potential treatments, routine monitoring, and early detection can make a difference in their eye health. So it really just boils down to preventative health. It boils down to care, specifically in this case to patients who are diabetic going to get their eye checked out, making sure that they don't have signs of diabetic retinopathy. Diabetic retinopathy progresses in two stages, which include the proliferative diabetic retinopathy and the non-proliferative diabetic retinopathy that varies from mild, moderate to severe. So in the early stages is the proliferative, and usually patients are asymptomatic. They don't know that they have diabetic retinopathy. They're not really showing signs of vision. They're just functioning normally. But then when they start to show sign, when they start to get floaters in their eyes, or they start to get blurred vision, when they start to even get glaucoma, that's when it has progressed to diabetic retinopathy, because then the eye is not really getting the adequate blood supply that the nerves are starting to damage. You have some newer that start to form that are weaker vessels that were there before. You have fluid around the eyes, building around the retina, and of course something called macular edema, where fluid is in the middle of the eye, and that's the progressive stage. That's the more severe stage of it. And then even to the point where there might be retinal detachment, when diabetic retinopathy has gone for so long and not being treated. And then eventually could lead to blindness. Fluorescence angiography is a procedure that involves ophthalmologists using a special camera to capture images of the retina. So the retina located at the very back of the eye. They're able to use the pictures to get a clearer view of the structures in the back of the eye, such as the blood vessels. FA, or the fluorescent angiography, to see what's going on at the back of the eye with the blood vessels and all that. FA is useful in finding and diagnosing eye problems such as ocular melanoma, macular pucker, macular degeneration, diabetic retinopathy, macular edema, which is the fluid in the eye, and vein blockage in the eye, called the branch retinal vein occultation and the central retinal vein occultation. When it comes to the background, basically, in terms of the articles that I used or that I searched up to conduct my research, some of the keywords that I used were diabetes mellitus, diabetic retinopathy, and psychological distress. The searched keywords were, like I mentioned before, diabetes mellitus, type 1 diabetes, type 2 diabetes, gestational diabetes, retinopathy, gender, and psychological distress. And I must add that gestational diabetes, the reason I went that direction to search is because usually when women have gestational diabetes, at some point in their life, they have a high likelihood of developing type 2 diabetes. I used EBSCOhost in searching various databases to gather scholarly books and peer-reviewed articles published between 2015 and 2023. So I searched journals such as the New England Journal of Medicine, Journal of Public Health Policy, PubMed, the American Journal of Epidemiology, American Journal of Public Health, the Journal of Public Health Management articles as well. Some of the studies that I found interesting was one from Leon et al. And Emmanuel et al. 2017 and 2018, which described the self-management of type 2 diabetes and the perception of adopters versus non-adopters of a patient portal pertaining to the application of diffusion of innovation theory. So the diffusion of innovation theory is one of those theories that are used in public health to study a patient's ability to adopt a new behavior. So in this case, is the self-management of type 2 diabetes, and then being able to adopt to new behaviors when it comes to being healthier, exercising, eating right, and all that stuff. Ansari et al. 2016 and Vicker et al. 2017 further describe the management of type 2 diabetes and the involvement of family preferences and challenges as they relate to the management of disease. So the role that the family plays, the interpersonal relationship of the individual, how people around them influence them, their family, for instance. The study explored the gap in literature pertaining to the under-researched area of the likelihood of gender-modifying the effect of psychological distress on diabetic retinopathy. So I felt like it would be good to kind of look at the differences in gender to see if the males are more likely to, develop diabetic retinopathy versus the females. All right, for the problem statement, the general public health problem was the association between psychological distress and diabetic retinopathy after controlling for covariates such as age, educational level, and income. The specific public health problem was determining the role of gender predisposition to psychological distress and diabetic retinopathy, which would fill a public health knowledge gap contributing to population health planning and implementation after controlling for covariates such as age, educational level, and income. So because this is a 3XM study, I had 3 different manuscripts and then 3 different problem statements. So for manuscript 1, the specific problem is the specific public health problem was determining the role of psychological distress to diabetic retinopathy, which would fill the public health knowledge gap, contributing to population health planning and implementation after controlling for covariates such as age, educational level, and income. And for manuscript 2, the specific public health problem was determining the role of gender to diabetic retinopathy, which would fill a public health knowledge gap, contributing to population health planning and implementation after controlling for covariates such as age, educational level, and income. For manuscript 3, the specific public health problem was determining the role of gender-related psychological distress to diabetic-related retinopathy, which would fill a public health knowledge gap contributing to population health planning and implementation after controlling for covariates such as age, educational level, and income. All right, for the purpose of the study, the purpose of the quantitative study was to investigate the relationship between psychological distress and retinopathy while considering gender. Examine the association between the independent variables, which are gender and psychological distress, and the dependent variable, which is diabetic retinopathy. For the study, I used a nationally representative database such as NHANES. So the NHANES stands for the National Health and Nutrition Examination Survey to analyze data. NHANES has the variables for depression and psychological distress measurement. In measuring psychological distress, the Patient Health Questionnaire, which is called the PHQ-9, was instrumental in showing how often individuals experience depressive symptoms. So that was very helpful in just kind of seeing some individuals exhibit, when it ties to psychological distress and apathy. The study was unique because it explored the gap in literature pertaining to the research area of the likelihood of gender modifying the effect of psychological distress on diabetic retinopathy. So the research question for manuscript 1 is, what is the association in psychological distress and diabetic retinopathy among U.S. adults after controlling for age, educational level, and income. And the main target here, the focus here is diabetic retinopathy. No hypothesis, there's no association between psychological distress and diabetic retinopathy among U.S. adults controlling for age, educational level, and income. And the alternative hypothesis is that there is an association between psychological distress and diabetic retinopathy among U.S. adults after controlling for age, educational level, and income. The research question for manuscript 2, being the focus here, is what is the association and diabetic retinopathy after controlling for age, educational level, and income? Null hypothesis is there's no association between gender and diabetic retinopathy after controlling for age, educational level, and income. And the alternative hypothesis is that there is an association between gender and diabetic retinopathy after controlling for age, educational level, and income. And for manuscript 3, the research question is, does gender modify the effect of psychological distress on diabetes-related retinopathy after controlling for age, educational level, and income? And the focus here is gender-related psychological distress. The null hypothesis is gender does not modify the effect of psychological distress on diabetes-related retinopathy after controlling for age, education. And the alternative hypothesis is gender modifies the effect of psychological distress on related retinopathy after controlling age, educational level, and income. The nature of the study and design. So the study was quantitative in nature. So quantitative research, we know, is different from qualitative research. My first doctorate, I conducted a qualitative study, and then this time around, quantitative. And I can honestly say that I prefer the quantitative method. So the quantitative research method relies on quantities of responses instead of the emotional insights of qualitative study. So one thing I like about quantitative study is that it deals with numbers, and the numbers tells stories. Like the numbers will tell you, lead you to a conclusion, it will tell you a story. Because quantitative research designs deal with close-ended questions that involves a list of answers, it is more efficient than the qualitative studies and reduces time consumption by eliminating the process of coding large amounts of open-ended answers. And I can relate to that because when I conducted a qualitative study, I had to deal with the coding. It was just more time consuming, not only creating the questions, but responses or getting some themes out of that the responses of the participants, and so it just took a longer time. So I understand the relationship between diabetic retinopathy and psychological distress, considering gender. So the format one, like I mentioned before, the hypotheses are no hypothesis that there's no association between psychological distress and diabetic retinopathy among U.S. adults after controlling for age, education, and income. The alternative hypothesis is that there is an association between psychological distress and diabetic retinopathy among U.S. adults after controlling educational level and income. For manuscript 2, hypotheses are no hypothesis is that there is no association and diabetic retinopathy after controlling for age, educational level, and income. And the alternative hypothesis is that there is an association between gender and diabetic retinopathy after controlling for age, educational level, and income. For manuscript 3, the null hypothesis is that gender does not modify the effect of psychological diabetes-related retinopathy after controlling for age, educational, and the alternative hypothesis is that gender modifies the effect on diabetes-related retinopathy after controlling for age, educational level, and income. The framework, the conceptual theoretical framework, basically I used the socio-ecological model because it It looks at the relationship between an individual and his or her environment. So how the individual influences the environment, and how the environment influences the individual. So the socio-ecological model developed by psychologist Yuri Bronfenbrenner enabled the understanding of the relationship between psychological distress and it assisted in evaluating the societal, community relationship, and individual factors, and enabled the exposure of the factors that places individuals at risk for psychological distress and diabetic retinopathy. So on the individual level, which is the intrapersonal scale, it looks at the individual willingness to engage in certain behaviors or to make certain decisions. On the interpersonal level, it looks at the individual's family, their musicians, their friends influencing their behavior. And then of course we have the community, the organization, the policy that plays a role into the types of decisions these individuals make. And in this case, people with diabetes, whether or not they are taking self-care seriously. The socio-ecological model factors on one level often influence those on another level. So he believes that one level plays a role into another level. So basically the interpersonal relationship, interpersonal level, the interpersonal level, they're basically at the end of the day, they're intertwined. The model provided some clarity on the different factors pertaining to the dependent and independent variables. The individual level of the model included the personal history and biological factors increasing the likelihood of developing diabetic retinopathy and psychological distress. So it looks also, the intrapersonal level looks also at the person's biological factors, right? Because people are genetically predisposed. For one, we know people are genetically predisposed to, or could be genetically predisposed to diabetes. It looks at that too. And then on the psychological level, whether or not they have diabetes, some people are genetically predisposed to depressive symptoms, to psychological issues or mental issues. So those factors include income and age. Individual level, prevention strategies could result in the prevention of behaviors, beliefs, and attitudes that could prevent psychological distress and diabetic retinopathy. So individual have the self-efficacy. They believe in themselves to engage in certain types of exercises or to be able to eat a very healthy diet. That plays a role in their prevention strategy. That also plays a role in whether or not they develop diabetic retinopathy or how bad their diabetes gets. The second level of the model, which is a relationship, emphasized the close relationships that could increase the risk of diabetic retinopathy and psychological distress. So an example would be if an individual says, okay, well, you know what, I want to start working out, and then they have friends who live very sedentary lifestyles that would rather sit at home and watch Netflix, that could influence the person. People's closest family members, their partners and social circle peers tend to impact the experiences and influence or contribute to their behavior. So again, people tend to adopt, the behavior of those around them. People around them influence their behavior. So if people around them are people who exercise and they're very cautious about what they eat, more than likely they'll adopt that behavior versus if it's the other way around where people are sedentary, they don't eat healthy and things of that sort, they're likely to adopt the behavior as well. At the relationship level, strategies for the prevention of psychological distress and diabetic retinopathy would involve promotion of positive peer programs for strengthening communications, family-focused prevention and mentoring programs, and the promotion of healthy relationships and problem-solving skills. So these are basically the support group. I know when we talk about the social determinants of health, we have the socioeconomic factors, that plays a role. And then we have the support groups too, the family or the community support groups. So having things like mentoring programs for people who are suffering from diabetes, those things help as well. The third level is the community, and it explores the neighborhood, the workplaces, and the schools where people from social relationships or form social relationships, and those settings might contribute to psychological distress associated with diabetes or diabetic retinopathy. So at the workplaces, do they have gyms? Are they getting compensated for living healthy? At the school places, do they have environment that encourages them to go out and work out or walk around? The communities too, or the neighborhoods might have do they have a built environment that enables them or encourages them to go out? Like some communities have parks with different exercise equipment. Are they encouraged? Do their physical encourage them to go out and engage in exercise? Strategies would involve the improvement of the social and physical environment in settings where individuals play, work, learn, and live. So the improvement of their physical environment, their built environment. Do they have walking paths, bike trails? On the community level of the model is residential instability and poverty. So that too, if they live in neighborhoods, where it's mainly low income individuals, more than likely they won't have much amenities. They might have a few that they need, but they might not have the best, or much, like I mentioned, they might have like built environment, built gyms. Some places, gyms, they have pools. They might not really have those things, and if they live in low income housing. The fourth level pertains to societal factors that may encourage the creation of an environment that inhibits or encourages psychological distress. So what does their society offer them? What society also, when we think about society, we also have to look at the public policy in that environment. What type of policy govern their behavior? The factors entail cultural and social norms that support behaviors that might lead to psychological distress and diabetic retinopathy. So the cultural and the social norms are good to point out too, because if a person lives in a culture where being thick or being overweight is beauty, it might not necessarily work out well with their condition if they're diabetic, versus if they live in an environment where, or in a culture where being slim is seen as beautiful, it might encourage them to work out more and be more active. So the cultural and social norms definitely plays a role. In terms of the method or design, the study was quantitative in nature, like I mentioned before. Quantitative research methods rely on quantities of responses instead of emotional insight. We just covered it. Because quantitative research designs deal with closed-ended questions that involves a list of answers, is just, in my opinion, can be more efficient than the qualitative study and less time consuming. All right, so the aim of the study was to understand the relationship between diabetic retinopathy and psychological distress while considering gender. And I used a cross-sectional design based on secondary data analysis for addressing the research question in the study. The design enabled me to explore the relationship between psychological distress and diabetic retinopathy among US adults, not just the African American population. Initially, I had that in mind, but it's US adults, while considering the role of the covariates: age, educational level, and income. My role as the researcher was as a quantitative researcher. A quantitative researcher analyzes and organizes data for the identification of causal relationships among variables. So again, part of what I enjoy about quantitative study or conducting a quantitative study is that I work with data and it shows me a causal relationship, between the variables. They use unstructured and structured data to gain deep insights about research topics of interest. The study design was cross-sectional, which means that it was observational. The justification for the use of the study design is that it enables the researcher to measure the exposure and outcome of the participants at the same time. So a person exposed to certain behavior, a certain environment, and what the outcomes are. So we look at both at the same time. Compared to cohort studies, which involves the selection of participants based on the status of exposure, and the case control studies that of participants based on outcome statuses. Cross-sectional studies involve the selection of participants using the study's exclusion and inclusion criteria. After the selection of the study participants, the researcher follows the study and conducts an assessment of the outcomes and the exposure. So cross-sectional designs are appropriate for the assessment of the disease prevalence in clinical-based samples, and for population-based surveys, cross-sectional study design can be inexpensive and conducted faster. So if we're dealing with surveys, then definitely it's a lot easier and faster to gather data than having to, chase participants down to interview them and get information from them. The data collection technique. So I used, like I mentioned before, NHANES, which is a nationally representative data. The study involved the examination of secondary data obtained from websites such as the United States Diabetes Surveillance System, from the Centers for Disease Control and Prevention, and the Diabetes Report Card to gather and analyze data about diabetes mellitus. It also involved data from the study participants who completed the diabetes questionnaire from the University of North Carolina Campus Health. I tried data independent variables from the 2020 data set retrieved from the USDSS and the CDC websites to evaluate the association between diabetic retinopathy and psychological distress among US adults. The secondary data sources enabled me to gather some analytical and descriptive data pertaining to diabetic retinopathy. So again, numbers. The data sets are in the public domain and reproducible, and there was no need to acquire special permission to gain access to them. So that's the beauty of it too, is that it's out in the public, you can access them. To reduce risk and biases and increase validity of the study, I examined whether the observed effects of the dependent variable related to the independent variables and not confounding variables. I examined the possibility of generating the results beyond the study population and observed how well the research instrument measured the studied construct. The internal validity can be minimal based on the use of multi-stage probability sampling technique used for the data set. For manuscript 1, in terms of the data analysis plan, I tested the relationship between psychological distress and diabetic retinopathy among adults in the United States while controlling for age, educational level, and income through a retrospective quasi-experimental study and using descriptive data analysis, multivariate logistic regression of secondary data, and bivariate analysis using chi-square test of independence, and included the statistical information at the end of the section. I set the significance level for the logistic regression and chi-square analysis at 0.05. I transformed the data into nominal data in the order of low, medium, and high, depending on the tertile of the range of data. Some variables were measured at the population level within different districts and by years, depending on the data collection method. Education was ranked based on the highest level attained and grouped in the categories of no education, primary, secondary, tertiary levels measured at a population level. The categories of no education were in measurements of low, medium, and high. The categories of less than secondary education were in low, medium, and high categories. And the tertiary education was in low, medium, and high category as well. I measured the individual level variable, still on manuscript 1, I measured the individual level variable sex as having 2 levels, which are female and male. The geographic location or places of residence covered in the study were grouped in districts found in various parts of the United States. I measured age at the individual level based on the medical subject heading or headings, which is MESH, for adults, which are age 19 through 44 years of age, middle-aged, which range from 45 through 64 years of age, and then aged, which went from 65 to 75, and then aged 80 and above. I collected available data on the population level through reputable agencies. For manuscript 2, I tested the relationship between the role of gender and diabetic retinopathy among adults in the United States while controlling for age, educational level, and income through a retrospective quasi-experimental study and using descriptive data analysis, multivariate logistic regression of secondary data, and bivariate analysis using chi-square test of independence. I set the significance level for the logistic regression and chi-squared analysis at 0.05. I measured the individual level variable sex as having 2 levels, which are female and male. And still on manuscript 2, the data analysis plan. So the geographic location of places of residence study were grouped in districts found in various parts of the United States. I measured age at the individual level based on the medical subject headings MESH for adults ranging from age 19 through 44 years of age, for middle age ranging from 45 through 64 years, and for age ranging from 65 through 79 years of age, and then age 80 and above. I collected available data on the population level through reputable agencies. I transformed the data into nominal data in the order of low, medium, and high, depending on the tertile of the range of data. All right, so still on manuscript 2, the data. Some variables were measured at the population level within different districts and by years, depending on the data collection method. Education was ranked on the highest level attained and grouped in the categories of no education, primary, secondary, tertiary levels measured at a population level. The categories of no education were measurements of low, medium, and high. The categories of less than secondary education were in low, medium, and high categories. So the tertiary education was in low, medium, and high categories as well. For manuscript 3, in terms of the data analysis plan, tested whether gender modified the effect of psychological distress on diabetes-related retinopathy after controlling for age, educational level, and income through a retrospective quasi-experimental study and using descriptive data analysis, multivariate logistic regression of secondary data, and bivariate analysis using chi-square tests of independence. I set the significance level for the logistic regression and chi-squared analysis at 0.05. I measured the individual level variable sex as having 2 levels, which are female and male. Still on manuscript 3, the data analysis plan. So the geographic location or places of residence covered in the study were grouped in districts found in various parts of the United States. I measured age at the individual level based on the medical subject headings, which is matched for adults, again, ranging from ages 19 through 44 years of age, middle-aged 45 through 64, age 65 through 79, and then age 80 and above. I collected available data on the population level through reputable agencies, and I transformed the data into nominal data in the order of low, medium, and high, depending on the tertile of the range of data. Still on manuscript 3, the data analysis plan. So some variables were measured at the population level within different districts and by years, depending on the data collection method. Education was ranked or was in ranks based on the highest level attained and grouped in the categories of no education, primary, secondary, tertiary level measured at a population level. The categories of no education were in measurements of low, medium, and high. The categories of less than secondary education were in low, medium, and high category. And the tertiary education was in low, medium, and high categories as well. All right, in terms of the results for manuscript 1, the result indicated that there was no association between psychological distress and diabetic retinopathy. The odds ratio was 0.96. The confidence interval 0 to 1.56. And they denoted that there was a strong evidence to fail to reject the null hypothesis. So there was no association with a p-value of 0.87. There was no association between psychological distress and diabetic retinopathy among U.S. adults after controlling for age, educational level, and income. The odds ratio still on manuscript 1 of 1.18 with a confidence interval of 0.37 through to 3.75 and 0.96 with a confidence interval of 0.44 to 2.10 indicated that there was no association between educational level and diabetic retinopathy after controlling for age and income, and denotes strong evidence for the null hypotheses being true. The odds ratio of 0.99 with a confidence interval ranging from 0.96 to 1.02 for age denoted strong evidence to fail to reject the null hypothesis. The results showed that there's no association between educational level and diabetic retinopathy. And the odds ratio of 0.9 with a confidence interval of 0.44 to 2.0 denotes strong evidence to fail to reject the null association between those who had some high school education, those that are high school graduate, and people with some college education developing diabetic retinopathy. The result shows that there's no association between psychological distress and diabetic retinopathy among U.S. adults after controlling for age, educational level, and income. All right. Still on manuscript 1, the result indicated that there was no association between age and diabetic retinopathy. It showed that there was no association between psychological distress and diabetic retinopathy when controlling for age. The results for manuscript 2. The result indicated that there was no association with a p-value of 0.06. There's no association between educational level and diabetic retinopathy. The odds ratio of 1.20 with confidence interval of 0.39 to 3.70 denoted strong evidence for the null hypothesis being true, and it was not. The odds ratio of 1.0, still on manuscript 2, with a confidence 7 to 2.13, denoted strong evidence to fail to reject the hypothesis, showing that there was no association between those who had some high school education, those that are high school graduates, and people with some college education developing diabetic retinopathy. The results showed that there was no association between psychological distress and diabetic retinopathy when controlling for education. All right, still on manuscript 2, the results indicate that there was no association between psychological distress and diabetic retinopathy. The odds ratio of 0.95 with a confidence interval of 0.57 to 1.57 denoted strong evidence to fail to reject the null hypothesis. There was no association between psychological distress and diabetic retinopathy among U.S. adults after controlling for age, educational level, and income with a p-value of 0.82. Still on manuscript, the result showed that there was no association between gender and diabetic retinopathy. The odds ratio of 1.65 with a confidence interval of 0.77 to 3.55 denoted strong evidence to fail to reject the null hypothesis. The results showed that there was no association between psychological distress and diabetic retinopathy when controlling for gender. Still on manuscript 2, the result indicated that there was no association, p-value of 0.30 between age and diabetic retinopathy. The odds ratio of 0.98 with a confidence interval of 0.96 to 1.01 denoted strong evidence to fail to reject the null hypothesis. The results showed that there was no association between psychological distress and diabetic retinopathy when controlling for age. Still on manuscript 2, the result indicated that there was no association between income and diabetic retinopathy with a p-value of 0.20. The odds ratio of 1.19 with a confidence interval of 0.92 to 1.60 denoted strong evidence to fail to reject the null hypothesis. The results showed that there was no association between psychological distress and diabetic retinopathy when controlling for income. For manuscript 3, where we looked at the male, the results are divided in two for males and females. And so these are the results for the males. The result indicated that there was no association between educational level and diabetic retinopathy. The odds ratio of 1.17 with a confidence interval of 0.32 to 4.33 denoted strong evidence for the null hypothesis being true, and it was not rejected. The odds ratio of 1.53 with a confidence interval of 0.41 to 5.70 denoted strong evidence to fail to reject the null hypothesis. The result basically showed that there was no association between those who had some education, those that are high school graduate, and people with some college education developing diabetic retinopathy. Still on the male results for manuscript 3. The results showed that there was no association between psychological distress and diabetic retinopathy when controlling for education. The result indicated that there was no association between psychological distress and diabetic retinopathy. The odds ratio of 1.21 with a confidence interval of 0.51 to 2.9 is strong evidence to fail to reject the hypothesis. There was no association with a p-value of 0.64 between psychological among U.S. adults after controlling for age, educational level, and income. The results for male in manuscript 3 indicated that there was no association between age and diabetic retinopathy. The odds ratio of 0.98 with a confidence interval of 0.92 to 1.04 denoted strong evidence to fail to reject the null hypothesis. The results showed that there was no association between psychological distress and diabetic retinopathy when controlling for age. Still on manuscript 3, the results for male. The result indicated that there was no association between income and diabetic retinopathy. The odds ratio of 1.13 with a confidence interval of 0.67 to 1.90 denoted strong evidence to fail to reject the null hypothesis. So the results showed that there was no association between psychological distress and diabetic retinopathy when controlling for income. Now, for manuscript 3 for females, the results for females indicated that there was no association between educational level and diabetic retinopathy. The odds ratio of 1.18 with a confidence interval of 0.22 to 6.42 denoted strong evidence for the null hypothesis being true, and it was not rejected. The odds ratio of 0.70 with a confidence interval of 0.20 to 2.40 denoted strong evidence to fail to reject the null hypothesis. Still on manuscript 3 for females, the result shows that there's no association between those who had some high school education, those that are high school graduates, and people with some college level developing diabetic retinopathy. The results showed that there was no association between psychological distress and diabetic retinopathy when controlling for education. The result indicated that there was no association between psychological distress and diabetic retinopathy. All right, so still on the female, the results for females, manuscript 3, the R of 0.70 with a confidence interval of 0.24 to 2.03 denoted strong evidence to fail to reject the null hypothesis. The result shows that with a p-value of 0.49, there was no association between psychological distress and diabetic retinopathy among U.S. adults after controlling for age, educational level, and income. The result indicated that there was no association between age and diabetic retinopathy. The odds ratio of 0, still on the female, manuscript 3, the results, the odds ratio show of 0.99 with a confidence interval of 0.96 to 1.01 denoted strong evidence to fail to reject the null hypothesis. The results showed that there was no association between psychological distress and diabetic retinopathy when controlling for age. The result indicated that there was no association between income and diabetic retinopathy. Still on the results for females in manuscript, the odds ratio of 1.27, confidence interval of 1.05 to 1.5 denoted strong evidence to reject the null hypothesis. So the results showed that there was no association between psychological distress and diabetic retinopathy when controlling for income. So in terms of the discussion, or what I gathered from the numbers, the results from manuscript 1, 2, and 3, the result shows that, although literature on the topic indicated a link between psychosocial functioning and diabetic macular edema or diabetic retinopathy, there's an uncertainty behind the direction and extension of the association. So yes, there might be some level of association, but is very uncertain. There's no, and the results that I gathered definitely weren't strong enough to say, okay, well, yes, there's an association between, those factors or those variables. The depression could be associated with the incidence and presence of diabetic retinopathy. Again, it depends on the individual. So the way one person manages stress or manages a health condition, another person might manage it differently. So depression might not necessarily be coming from the diabetic retinopathy. It might be genetically predisposed. It might just be from the individual. Psychosocial functioning entails social and emotional factors that relates to depression, vision-specific distress, anxiety, depressive disorder, social and emotional well-being, and diabetes-specific distress. Many pathophysiological mechanisms, such as increases in circulating cytokines, glucose and insulin resistance, alteration, and dysregulation of hypothalamic pituitary adrenal axis could play contributory roles in the pathogenesis of diabetic retinopathy. So again, it might vary for individuals. It might just depend on what's going on with the person's genes or in the person's body, which people are different. People's bodies are different. The interaction shows a probable bi-directional relationship between psychosocial functioning and diabetic retinopathy. So the results show that there was no association between those who had some high school education, those that are high school graduates, and people with some college education developing diabetic retinopathy. So one thing that I found out was that, yes, you would think that the more educated people are, the more they'll take their health more seriously. Sometimes it's true, other times it's not. But the main thing here, when it comes to diabetic retinopathy and psychological distress, really boils down to self-care. It boils down to people who are, and you don't necessarily to be a patient or be overeducated for you to know that if you're diabetic, you need to eat healthy and that you need to be active. You need to not live a sedentary. So they also indicated that the results also indicated that there was no association between psychological distress and retinopathy when controlling for education. So to limit and prevent the progression or development of diabetic retinopathy, it is necessary to have a coordinated management strategy which involves or includes early diagnosis of the disease, glycemic control, and regular screening of the diabetic retinopathy risk factors. So those factors that will put an individual at risk for developing diabetic retinopathy, if they're caught on time and they're treated or managed, then more than likely won't progress to diabetic retinopathy. Or if the person already had diabetic retinopathy, it won't progress to the proliferative stage or the severe stage. Preventative care would entail comprehensive ancillary tests, patient education, and dilated eye exam implemented through a multidisciplinary team that comprises of retina specialists and primary diabetes care providers, such as diabetologists, endocrinologists, and primary care providers. So it's a whole team that could help in making sure that a patient's health does not deteriorate to them having or developing diabetic retinopathy when they're suffering or when they have diabetes. Despite the dissemination of the guideline recommendations for regular patient education and screening, many individuals with diabetes do not receive the ophthalmological care needed for the prevention of blindness and visual impairment. So sometimes people don't know, sometimes these patients aren't educated enough on how to take care of themselves when they have diabetes. Patient focus would have an impact on patient self-efficacy and knowledge as they relate to the management and prevention of diabetic retinopathy. So the key word there, or the main thing there is self-efficacy. So for someone who's not quite educated on managing diabetes, they might not have the self-confidence to be able to do it, or might not even know what to do. So the more there's, the patient education is implemented to where they're aware of what to do to take care of themselves, the more self-efficacy they have, the more they're just more confident in taking care of themselves. Online education could assist in changing patient practice, competence, and knowledge. So we live in a digital age now. So for patients who aren't able to physically go get this education, online helps as well. An effective tool for building patient awareness and knowledge about diabetic retinopathy and for motivation or for motivating patients to take actions towards diabetic retinopathy self-care is patient education. So basically, when patients get the patient education, the education they need on how to take care of themselves, the likelihood of them developing diabetic retinopathy becomes slimmer, or even going blind, or having further vision damage when they already have diabetic retinopathy becomes slimmer. The duration of diabetes mellitus is associated with the severity of diabetic retinopathy. So the more severe the diabetes gets, the more likely they have diabetic retinopathy and could progress to even blindness. Considering the significant increase in human lifestyle and the aging population, diabetic retinopathy has become devastating to healthcare systems and individuals. So the increase in human lifestyle means that people will be living longer, and then it means that people who are diabetic care. And so it's that to have that system in place to where these individuals are helped and on time as well. Although aging plays a significant role in the onset of age-related diabetes, its indirect or direct effect on the development of diabetic retinopathy are understudied. So it's a lot more that goes into the study of age playing a role in the development of the diabetic retinopathy, and I think that's an opportunity for further study as well. Some studies emphasize that the development of diabetic retinopathy and age-related degeneration have similar risk factors, which explains the prevalence of increased visual impairment and diabetic retinopathy in the aging population. So naturally, whether a person has diabetes or not, the vision tends to deteriorate as we age. And so diabetic retinopathy is seen concurrently with people who are aged, because naturally their vision fade anyways. There was no association between income and diabetic retinopathy ratio of 1.20, which denoted a strong evidence to fail to reject the null hypothesis. So the results show that there's no statistically significant association with psychological distress and diabetic retinopathy for income. So regardless of how much money a person makes, it doesn't they have health literacy. It doesn't necessarily mean that they have the patient education to be able to take care of themselves well if they're diabetic. In working age people living with diabetes, diabetic retinopathy is the cause of blindness. Diabetes-related health outcomes and diabetic retinopathy disproportionately affects minority and United States. Mainly because when you talk about the social determinants of health, they basically on the short, they get the short end of the stick. They are on the low end. So what I mean by that, there might not exactly be is available to them to where they're getting the education necessary to let them know how severe that their situation is if they're diabetic. They're not eating the best food, the healthiest food. They're not making enough money, even if they know they're not making enough money to be able to purchase medications and get the type of specialist care that they need. They might not have the insurance. So it's just different things. They might not be in the best physical environment to be able to work out or not live a sedentary lifestyle, be active. Racial disparities and those associated with the social determinants of health, such as education, healthcare access, geography, and socioeconomic status play roles in the screening and prevalence of diabetic retinopathy. There was a strong evidence to fail to reject the null hypothesis, and the results indicated that there was no association between gender and diabetic retinopathy. So female males can equally be affected by diabetic retinopathy if they're not taking care of themselves properly, diabetic. It showed that association between psychological distress and diabetic retinopathy when controlling for gender. The main cause of diabetic retinopathy in adults residing in the United States is diabetes, and there's sex gender differences in diabetic patients. So based on my research, there are differences in the female and male anatomy and how they function, but generally it doesn't necessarily mean that one is more at risk for diabetic retinopathy versus the other. So some studies emphasize that compared to women, there's a significantly higher prevalence of diabetic retinopathy, both pre-proliferative or proliferative diabetic retinopathy and non-proliferative diabetic retinopathy in males. And it depends on the age, and there are factors that play into this. The age, the race, ethnicity, and so forth. The results in the literature about differences in diabetic retinopathy based on sex gender are controversial. And rightfully so, because there are other factors that plays a role in whether or not a person has diabetic retinopathy. Although some studies report that men have higher risk of diabetic retinopathy, others emphasize that women have a higher prevalence of the disease. So women have a higher prevalence of diabetes, but then men who are diabetic have a higher prevalence of diabetic retinopathy. But that's some studies, not all of them. Other studies with type 2 diabetes patients indicate that for the development of diabetic retinopathy at baseline, the female sex has a higher prevalence of proliferative diabetic retinopathy. A few studies did not report significant differences in diabetic retinopathy for gender. In terms of limitations, the study has some limitations. One being the lack of patient education and regular screening for diabetic retinopathy, which leads to the inability of many individuals living with diabetes in the United States not receiving ophthalmological care needed for the prevention of visual impairment and blindness. So the study didn't quite look at the had patient education and those who didn't, who went for regular screenings, and those who didn't go for regular screenings. The educational and screening factors and those lacking ophthalmological care were not controlled in the study because of the constraints of data availability and sample size. Still on limitations, factors such as lack of effective communication and lack of care by healthcare providers regarding patients and the extent of diabetic retinopathy progression were not controlled in the study. Non-binary and transgender respondents were not controlled for in the study because the sample size was not large enough for this category of respondents. In terms of the social change implications, the study aimed to determine the relationship between psychological distress and diabetic retinopathy while considering the role of gender. So the findings of the study hopefully would contribute to positive social change because it will provide new insights pertaining to ways that the improvement of the pathophysiology of diabetes and diabetic retinopathy could lead to the improvement of psychological distress. The study findings could facilitate the implementation of national policies geared towards the empowerment or assistance of individual adherence or healthier lifestyles leading to the prevention of diabetes mellitus and diabetic retinopathy. So it would encourage people who live with diabetes to seek additional information and enroll in classes for diabetes education. It might encourage additional research on diabetes-related laser eye surgery, intraocular drug therapy for vision impairment, and neurodegeneration. Stakeholder-sponsored grants could become available to provide funding for educational promotion through the media pertaining to diabetic retinopathy and psychological distress. And this basically comes to the end of my study or the end of my presentation. And I just want to thank my committee members, Dr. Sri Banerjee and Dr. Raymond Panis, and everyone who has contributed in making sure that this becomes a reality, that my study comes to fruition. I'm very grateful in general. So right now, I'm open to questions.
Thank you, Claret. This was a very thorough presentation, great presentation. At this point, I'm going to turn this over to Dr. Panis, and he will ask you some questions, and then I will ask you questions.
Okay. So my first question is, what was the biggest surprise that you came across in your research findings?
I must say that the main surprise I came across was that I was thinking personally, the reason I chose to study was because I know someone who is diabetic, who has type 2 diabetes. The person started to complain of vision loss, right? I saw their lifestyle degenerated. They couldn't work like they used to. They couldn't socialize like they used to. And so I was hoping to see more of that in the studies during my literature review. And I saw some of it, but I was thinking that it would be way more significant because losing one's vision is not something, it's not something that people look forward to. It's not something that people would take lightly. It's something that's profound. So I was hoping to find of that correlation between the psychological distress or even the depression that's tied into the diabetic retinopathy.
Okay. And based upon your findings and everything, where do you see this fitting into the greater body of knowledge?
I see the study being used a lot by, first of all, people who are diabetic could really benefit from this study. Healthcare providers could benefit from this study, so that way they know that it's very important to really implement that patient education. I see people like ophthalmologists, optometrists benefited from this study, from the findings specifically, and just the general public. Really, I don't see how this study won't be able to fit into the grand scheme of things when a lot of people, or millions of people, not just in the United States but around the world, have this disease. They're suffering from some form of diabetes, type 1, type 2, gestational, and so forth.
So how are these people going to learn about your data, in order to make that type of social change or that social impact? What are you going to do with it?
Like my friend, I must say that one thing that one thing that I'm passionate about when it comes to this second study is to make sure that it's published. And so I look forward to publishing, and making sure that my work is not just, because if it's just sitting on ProQuest, not everyone can access it. So I want it to be published in different journals. Personally, I'll advertise it on my social media handles. I want people to read it. I'll send it out to people who I know, and people I know that would benefit from it, right? So yes, definitely. It's just making sure that I publish it, making sure that I present more at conferences so people get to learn about my study.
Okay. And now that you've gone through this dissertation process, what was the biggest surprise about yourself in completing this research?
I must say that, because I've always told myself that I'm not a math person. So I've always leaned towards the qualitative study. So my first dissertation, I did a qualitative study because I felt like I didn't want to deal with the math, right? So one thing that surprised me about myself is that I'm actually good in math, and not just good in math, but I can make sense out of it, right? I could make sense out of it. And I actually prefer quantitative now to qualitative. So if I were to do it all over again, I would just do quantitative versus qualitative.
I see. Okay, one last question for you. After you complete all this, people are going to start referring to you as doctor. So what are you going to be as a PhD?
So I have to say, because I already have a doctorate degree, I'm already being referred to as at the moment public health coordinator at University of Martin. So everything public health comes to me, right? I teach all the public health classes and everything. But the whole referring to me as a doctor, I think I've past that imposter syndrome. I'm used to it now. And so what I'm looking forward to is just really impacting people with what I've learned, really.
Okay. Well, thank you for all of that. This was very comprehensive, probably the longest presentation I've had to sit through. But again, it was very thorough, very interesting, and thank you for that. So I'll turn it over to Dr. Banerjee.
Thank you, Dr. Panis, for those great questions. I wanted to revisit, this is on another, something that you taught me, Dr. Panis, in a residency. You said that you can be referred to as doctor, and then in Europe, this is something of a rule that they do that. So I'm glad you brought that up, Dr. Panis. And some of the other questions. So from my angle, Claret, again, very comprehensive presentation. I had some questions that I was writing down. So if you go to slide 58, I think we're going to have to look at this a bit more. Let me go to slide 50. Just something minor. I'm not saying, this is something, just something to learn, just learning moment, is that when you have, one not included, like 1.0 not included in the CI, That means what you do is you reject the null hypothesis. And we're going to have to look at the confidence interval here. So does that make sense, kind of? So you can use p-value, and then you can look at the confidence interval to determine if the conclusion was significant.
Okay. Okay. So you're saying, so where it says the odds ratio of 1.27 denotes strong evidence to fail to reject. So I'm supposed to reject the null hypothesis.
Well, right. I'll revisit the dissertation and take a look. So just with minor revisions there. I had some questions about. Let me take a look here. Oh, you were talking about population level, and within these slides. What do you mean by population level?
I believe the population that I was referring to is the U.S. population, because I know initially I wanted to study African Americans, but then I just ended up doing adults in the U.S. So that's what I was talking about, basically. Yeah.
Right. That sometimes gets confused with individual level versus group level, the unit of analysis. Just terminology, nomenclature, just to keep in mind. I wanted to comment on the organization of your slides. They were very well, well organized. You didn't have too many bullets on each slide, and this is how you would do a presentation. So kudos on that.
Thank you.
So diffusion of innovation theory versus health belief model. What can you remind us why you selected diffusion of innovation theory?
Diffusion of innovation theory deals with adopting a behavior, right, in terms of public health. And so I feel like for people who are diabetic, they might not necessarily have the best habits, right? Some of them might be sedentary, and so they might need to adopt new habits of exercising regularly, right? They might need to adopt new habits of eating healthier diets. So if they're used to eating the McDonald's or other, junk food, they might need to adopt to eating healthier, eating more salad, eating more protein versus carbs and things of that sort. And so I felt like the innovation of the adopter theory would be more beneficial. It would fit in more to show the progression of people's adoption to their new behaviors.
No, that's great. I was kind of wanting to revisit. I'm really glad you brought up underdiagnosed because there's so many people walking around with diabetes and don't know it. What is the effect of that?
The effect of that is that, first of all, preventative health is a big thing, right? So the earlier we know that there's something wrong, the better for us, right? It's always good to go for screenings, always good to go for physical exams. And so for these individuals who don't know that they're diabetic, what that shows is that they're not really engaging in preventative health. They're not really going for that annual checkup where their blood work, is being ran and things of that sort. And so they need to do better. Like they need to go and take that more seriously, getting that physical exam done and things of that sort. So I just feel like that's an area that needs to be looked at. So that way we reduce the number of people suffering from diabetes or people who come down with diabetes. Because if those people are at the pre-diabetic stage, they might be able to reverse that pre-diabetes versus being full-blown diabetic and then looking for ways to remedy the situation.
Great. Not many people know, actually. I'm glad you brought that up because I was going to say something about pre-diabetes. Right. Pre-diabetes is preventable and not many people know that. So that's great. I think I asked about Dr. Panis asked about No, I just wanted to ask you, well, I think you kind of said that, why you preferred quantitative over qualitative since you've done both. Um, and you said that now you find quantitative easier and great to deal with. And I'm glad you had that conclusion after we completed the dissertation. So, that's great. So that's all of my major questions. At this point, I think Dr. Panis and I, we can kind of come to a common consensus as to what to do next.
All
Dr.
right.
Panis?
Thank you. Thank you very much for the opportunity. Thank you.
Mm-hmm. Dr.
Sorry,
Panis, did you?
I was on mute there.
Oh,
Yeah, I don't necessarily have any particular issues with the dissertation or anything like that. You did bring up the question about this one particular odds ratio, which you can determine whether something is correct or incorrect there, and if so, adjust it accordingly. And I'm not sure if the question is something to do with this particular question being sort of a two-part question and having strong evidence to reject or fail to reject on one part and then rejecting it on another part. Because if A is true and B is false, then it ends up being false, essentially, where you both have to be true in order for it to be true. So I'm not quite sure if that's the situation here. But anyways, I'll let you deal with that one. But otherwise, I have no objections to it.
That's great, Dr. Panis, and I agree with you completely wholeheartedly that this can go through into the next stage, and we'll take a look, Dr. Panis, about that odds ratio and how that works. I remember the time when Dr. Panis told me that I was ready to go, and similarly, Dr. Panis and I have approved this. So congratulations, Dr. Onukogu.
Thank you. Thank you. Thank you. Thank you. I appreciate all your assistance and your feedback and everything. Definitely wouldn't have made it this far without you guys. Dr. B, I don't know what I would have done without you, honestly. I really don't.
Claret.
I don't think,
No,
coming back, coming back a second time for me was a challenge. It was a mental challenge for me because I didn't know that I wanted to go through it the second time. But thanks to you, you really have helped me through this journey. I'm very, very grateful, honestly.
Well, all I have to say is this is all because of Dr. Panis, because I wouldn't be here if he wouldn't have approved mine either. So I'm just taking what Dr. Panis taught me. So you should thank him.
Thank you, Dr. Panis. Thank you so much. Thank you.
Well, you're welcome. And Dr. Banerjee got to where he's at, in part because of all his own efforts and stuff like that. I was just a guide along the way. So, anyways, it's nice to be thought of that way. But he did a lot of the work himself, and I'm sure you did a lot of the work yourself. And you truly deserve all the credit. And we look forward to you publishing this data and stuff like that. And obviously we're here to help you from that perspective too. So anyways, congratulations.
Thank you.
Gives you a good reason to celebrate this weekend.
Yes, absolutely. Absolutely. Yes. Yes.
Yeah. Take these milestones and celebrate them. So they're important.
Yes. Yes. Yes.
Yeah. Anyways. All right.
All right. Well, thank you, Dr. Panis. Thank you, Claret, and we'll adjourn this meeting at this point.